Good morning, good afternoon. I would like to thank the organizer, Dr. Naimer, Dr. Cazzola, Dr. Buxton, and the MDS Foundation for the opportunity to speak today. My name is Elsa Bernard, and I would like to discuss with you new steps towards genetically inspired classification of MDS. I have no disclosures. The current WHO classification for MDS is based on an integrative approach that combines morphology, immunophenotyping, and clinical features, as well as, to some extent, genetic features. It classifies MDS into 6 distinct diagnostic categories. And also relevant for that talk, there are the existence of broad categories in the WHO as myeloid neoplasms with germline predisposition and therapy-related myeloid neoplasms. Apart from the SF3B1, which is including in the definition of MDS with ring sideroblast, MDS-RS, and deletion of chromosome 5q, there is really no distinction of genetic etiology in the current WHO classification. Yet, thanks to many different studies from several groups in the last decades, we have a very good knowledge of the molecular landscape of the disease, where more than 90% of patients have a molecular lesion recognized as oncogenic. But really, the genetic heterogeneity of the disease has challenged incorporation of molecular markers into classification schemas. But only 10 to 15 genes are mutated in more than 5% of patients, and patients do have, in average, 3 to 4 driver mutations. Another challenge in that most mutated genes in MDS are not specific, and they are also found in other disorders, other myeloid neoplasms, or other conditions such as CHIP, clonal hematopoiesis of indeterminate potential. So that in aggregate, MDS mutations tend to be not frequent enough or not specific enough to serve as presumptive evidence for MDS. Yet, as we improve our understanding of the genetic and pathobiology of the disease, there are opportunities to build a genetically driven classification for MDS. Indeed, we observe strong and non-random patterns of commutation and mutual exclusivity between gene mutations and or cytogenetic lesions. And we also observe strong genotype to phenotype relationships underlying the clinical relevance of molecular markers. But given the genetic complexity of MDS and the very diverse patterns of commutations, we do need systematic approaches for the development of MDS genetic classifications that extend beyond univariate analysis and single gene markers. Such approaches have been successfully used across the board of myeloid neoplasms in AML and in MPN, and more recently also in MDS in a study published recently in JCO in 2021. So the primary goal of such approaches is to discover the order of the chaos, where we go from a diverse set of patient genotypes as depicted here on the in-map of the left, with patients as column and molecular alterations as rows, and where we see that we lose all kinds of structure shortly after the top mutated genes. From there, we can build a structure grouping of patients, as shown on the right, where molecular subgroups are defined by a combination of non-overlapping gene mutations and or cytogenetic alteration. And we are investigating such integrative clustering approaches within the IWG, International Working Group, which is a collaborative effort involving 24 MDS centers across Europe, South and North America, and Asia. And part of those data will be presented at this ASH meeting in session 637, abstract 61, for the prognostic angle of the study. And in today's talk, I'm discussing classification. I will discuss published literatures as well as some analysis performed in the IWG dataset for classification. The IWG data consists of 3,300 diagnostic MDS samples with detailed clinical annotation. Samples have been analyzed for driver mutations in more than 100 genes, as well as cytogenetic alterations and allelic imbalances. And we also work with the Japanese MDS consortium with a cohort of 1,100 patients to challenge and validate our findings. With regards to methodology, we study based on unsupervised de novo classification, we study the molecular composition and the clonality within each defined group, where really the challenge is to extract some rules that are amenable to clinical adoption. We questioned the clinical relevance of molecular classes with regard to their association with clinical presentation, morphology, WHO, as well as outcomes. And what is clearly emerging from this kind of exercise is that disease-defining markers that define molecular classes are diverse and vary in their complexity, ranging from single gene markers to single genetic features that extend beyond the wild type or mutated status of a gene to more complex definitions involving co-occurrences and or mutual exclusivity between different gene mutations or cytogenetic alterations. And during this presentation, I will give a few vignettes that span this complexity, going from single gene markers such as UBA1 and PM1, DDX41, and of course SF1, but I will also discuss SF1 in the context of more complex genetic heterogeneity and how that heterogeneity matters, and I will discuss also biallelic TP53. So in the IWG data, by performing such integrative clustering approaches, we identified 17 non-overlapping molecular subgroups that classified 86% of patients, and that varied in size, ranging from very small classes of 1% of patients to larger classes of 15% of patients. And of course, I will not detail each one of those subgroups in detail, but highlighting their clinical relevance, we observe strong variation in the distribution of bone marrow blasts across the classes. And one of the entities associated with a lower level of blasts is the group of patients without a recognizable oncogenic lesions. Indeed, 6% of patients of MDS under panel sequencing do not have a driver mutations or cytogenetic lesion. And this group of patients is interesting in itself. They're present with younger age, a female bias, and a favorable outcomes with a median overall survival of 8 years or so. And they are enriched for MDS, SLD, MLD, but a subset of those patients also present with excess blast. We do have generated for those subset whole genome sequencing data that we're currently analyzing and hoping to be able to share those results with you soon. And we are also screening for candidate gene mutations in the other cases of no mutations in MDS, SLD, MLD. In particular, we are screening for mutations in UBA1. And the reason why we are screening for mutations in the ubiquitin activating enzyme UBA1 is based on the seminal study from Beck and al. In 2020, where they defined a new autoinflammatory syndrome called VEXAS, linked to somatic UBA1 mutations. VEXAS is characterized by vacuoles in the cytoplasm of hematopoietic precursor cells and the risk of the development of hematologic neoplasia, where it has been described that 25% of VEXAS patients do have MDS. And vice versa, we know that a significant proportion of MDS patients have autoimmunity, autoinflammation symptoms. And following the Beck and al. Study, a couple of reports have shown that in MDS cohorts selecting for autoinflammatory disease, UBA1 mutation was found in about 10% of patients. In our data, which are not selected for autoinflammatory disease, but in that case, the absence of recognized driver mutations, Maria Serenko in the lab have developed a ddPCR assay to screen for UBA1 hotspot mutations, and they found that UBA1 mutations can resolve 10% of cases without recognized oncogenic lesions, and they seem to be associated with a worse outcome than other cases. Those are preliminary data that we are now extending the screening and the number of cases. Beyond the cases with no unrecognized driver mutation, the first well-recognized molecular marker I would like to mention is of course SF1 mutant MDS, where mutations in SF1 are really a good candidate marker for MDS classification. They are frequent in MDS, so half of MDS patients do have splicing factor mutations, and the most frequent are mutations in SF1. They are frequent early event in MDS pathogenesis, and they also strongly detect disease phenotypes associated with ineffective hematopoiesis, and strongly associated with the presence of ring sideroblasts. where more than 80% of patients with MDS-RS, MDS with reintroducible do have SF-sub1 mutations. And they are associated with an indolent clinical course and a favorable outcomes in patients with MDS without excess blast. And indeed, earlier this year, a study from the International Working Group led by Dr. Malkovati proposed diagnostic criteria to be including in the WHO classification to define a subset of SF-sub1 mutant MDS as a distinct disease subtype. But given that SF-sub1 mutations are also found in individuals with CHIP or other hematologic cancers such as CLL, they maintain the established hematologic and morphologic requirements for the diagnosis of SF-sub1 mutant MDS. And they also defined a series of exclusion criteria with other cytogenetic alterations or other gene mutations. And I will come back to those exclusion criteria at the end of the talk when I'll discuss the importance of the genetic context in which mutations occurs for classification in MDS. So the next vignette I would like to discuss is NPM1 mutated MDS. Mutations in NPM1 are rare in MDS, but still observed in 1% to 2% of patients. And they are predominantly found in MDS with excess blood, but also in other subtypes such as MDS-SLD, MLD. They are virtually identical between MDS and AML with regard to patterns of commutation, predominantly DNMT3A, FLT3 or other signaling genes, and also with respect to clonality. And while in AML, NPM1 mutations are markers of favorable outcomes and favorable response to therapy, in our MDS cohort, they were associated with poor overall survival and high risk of AML transformation. And the presence of NPM1 mutation in MDS has implications for therapeutic decision-making. And for example, in that study from the MD Anderson group, with the limitation of being a retrospective study with potential bias for selection, they show that NPM1 mutated cases had favorable survival following treatment with chemotherapy or chemotherapy plus transplantation. And these highlight the need for prospective study for investigated treatments for NPM1 mutated MDS. The following vignette I would like to discuss is based on DDX41. I'll be brief because we will hear more about genetic predisposition to MDS in the next talk by Dr. Malkovati. So mutations in MDS are frequent. They are observed in about 3% to both AMDS and AML. They occur in a very characteristic patterns of a germline loss of function mutations, followed in about 60% of cases by a secondary somatic hit with dominant representation of hotspot substitution at the arginine 525 position. They are also characterized by a late onset of the disease and a male bias. In the current WHO classification, myeloid neoplasms with germline DDX41 mutations are classified within the broader group of myeloid neoplasm with germline predisposition. However, germline recognition can be challenged in those individuals due to inconclusive personal or family review, as well as the late onset of the disease and individual presenting with, in average, 60 years old or more. In addition, data presented by Dr. Makishima at last EHA meeting show that the patterns of molecular presentation of DDX41 mutations are diverse, and that 50% of cases with DDX41 mutations do have both germline and somatic, 40% have germline only, and also rare, 10% of cases do have somatic only mutations in DDX41. And those patterns are consistent with the one we observed in the IWG data, where we also show that with the limitation of the absence of a matched normal tissue, 80% of individuals have likely germline mutations, among which 60% do have a second somatic hit, with no detected difference in age of presentation across the different subgroups. We observe that DDX41 mutations are strongly enriched for excess blast and risk of AML transformation, but conversely and intriguingly, a favorable overall survival, in particular in the subset of excess blast. And those intriguing associations might be explained by the favorable outcomes of the DX41 mutated patients following treatment with hypomethylating agents, HMA. These favorable survival have been shown in a study by Seber and al. In 2019, and there are other lines of evidence from Dr. Nanya that are currently under review that support that statement of favorable survival following HMA, such as the DX41 mutations are emerging as a marker of favorable outcomes following treatment with HMA, but this specificity between treatment and the DX41 mutant MDS or AML needs to be investigated in large and prospective studies. While we've discussed single gene markers, I'll like now to move to different types of marker that involved a single gene or single locus, but extend beyond the wild type or mutated status of a gene, then this is the allelic TP53. TP53 mutations are frequent in myeloid neoplasms, and they are associated with aneuploidies, complex karyotype, high-risk disease features, and dismal prognosis, especially when co-occurring with complex karyotype, as well as resistance to all type of standard therapy. We've previously shown that in MDS, two-thirds of TP53 mutant patients do have biallelic alteration of TP53 through the combination of multiple mutations or mutation with deletion of congenital LOH, and that this is really the biallelic targeting of TP53 that associate with genomic instability, complex karyotype, and dismal prognosis across the modes of biallelic targeting with high rate of AML transformation. And at this ASH meeting, we will hear more about biallelic targeting of TP53 as a driver of clonal evolution and disease progression that seems to be universal across myeloid neoplasms. In the talk presented in the plenary session by the Dr. Mead group, they will present a model of evolution to secondary AML from TP53 mutated MPN that involves a secondary biallelic hit of TP53. And the potential definition of a class of patients in the MDS classification that utilizes TP53 as a marker has further relevance given the emergence of different therapeutic options targeting TP53 mutant MDS or AML. And we also hear at this ASH meeting more about the long-term follow-up analysis of the combined phase 2 trials of APR246, a small molecule stabilizing the mutant P53 functions, together with azacitidine, that were led by Dr. Salman and Dr. Clouseau. And we will also hear more about TP53 mutant myeloneoplasm at this symposium by Dr. Salman. But with regard to the current classification, cases with biallelic TP53 classified predominantly in MDS with excess blast, but also in other subtypes such as MDS, SLD, MLD. And there is really no distinction in outcomes between the W2 subtypes among cases with biallelic TP53. And similarly, there are the cases with primary MDS TP53 biallelic or therapy-related MDS TP53 biallelic are virtually identical with regard to outcomes. Which brings me to a very short section I would like to discuss, which are therapy-related myeloneoplasms, where currently the WHO defines therapy-related myeloneoplasms as a distinct entity combining patients that have previously received treatments for non-myeloid disorders. We know that therapy-related MDS is enriched for complex cytogenetics, monosomal karyotype, as well as isolated monosomy 7, and mutations in TP53 and PPM1D, a regulator of TP53. Yet, we do observe diversity in the genetic etiology of therapy-related MDS. And here on the heat map of the left, we've grouped the therapy-related MDS cases in different subgroups, in 4 different subgroups, one with TP53 complex karyotype, another subgroup with monosomy 7 or ZBP1 mutations, a third subgroup with complex mutational patterns involving U2F1, SRSF2, with commutation with BCOR, RUNX1, among others, and then a more simple subgroups with SF7 mutations and a few other commutations. And we do observe that the outcomes of therapy-related MDS are different across the subgroups, and they are no different from primary MDS per different subgroups. So when we account for the genetic context, we don't see differences, main differences between primary and therapy-related. And this concept of how the genetic context matters, I will finish by that concept, and I will illustrate it using SF7 mutant MDS as a paradigm and as an example. So this will be my very short, very few last slides. So we started the talk showing that SF7 mutant MDS is a distinct disease entity, and in the criteria for defining that entity, there are exclusion requirements with other cytogenetics or other gene mutations. And indeed, if we consider the different subset of mutant SF7 mutations, we do see a subgroup of 7% or so of SF7 mutant cases that co-occur with isolated 5q. 15% of cases do co-occur with a more complex patterns of commutation that involve in particular commutation is RUNX1 or BCOR-like and or STAC2. And then a third and large subgroup, which comprises isolated SF7 or SF7 mutations, mainly with simple commutations patterns with the TET2, DNMT3, and SXL1. And interestingly, there are strong epistatic interaction with respect to outcomes across some of those subgroups. In particular, we do observe strong epistatic interaction between SF7 mutations and isolating 5q. And when we consider the outcomes of specific to SF7 cases across those different subgroups, we see that the favorable outcomes of SF7 is restricted to only one of the subgroup, which highlight that the association is modulated by the patterns of commutation. Beyond the association with outcomes, we also see differences in the variant allele fraction across the subgroups of the SF7 mutations, as well as in relation with different levels of fringe sideroblast. So to conclude, there are single gene markers that can be easily incorporated into classification schema. This includes, for example, UBA1 mutations that are maybe frequent in MDS with otherwise unrecognized lesions, NPM1 mutated MDS, which is no different from AML, and DDX41 mutations that define a distinct entity with candidate therapeutic implications. Biallelic TP53 mutation is a universal marker of aggressive disease across myeloneoplasms and really a distinct entity. Mutant SF7 is more meaningful than MDS with ring fibroblast, but there is a strong role for the genetic context, and the importance of the genetic context is also highlighted in therapy-related MDS. With that, I would like to thank you very much for your attention. I would like to thank all the IWG collaborators that participate in the study with some of the data that I presented today, and Dr. Papa Manuel, my mentor at MSKCC, as well as other colleagues. Thank you very much.